Tell us about your experience in a medical surgical or general medical ward. What were the most common conditions you treated?
During my time in a busy 36-bed medical surgical ward, I gained extensive experience managing patients with a variety of acute and chronic conditions, including pneumonia, chronic obstructive pulmonary disease, COPD, heart failure, diabetes mellitus, postoperative wound infections, and sepsis. Each day presented a mix of complex cases, requiring strong clinical judgment and time management to prioritize competing demands safely. One particular challenge I recall was caring for multiple postoperative patients while a newly admitted patient with diabetic ketoacidosis, DKA, required urgent attention. The situation demanded rapid assessment, coordination, and teamwork. My task was to stabilize the new admission while ensuring postoperative patients continued to receive timely care. I quickly assessed the DKA patient's airway, circulation, and glucose levels, initiated fluid resuscitation as per protocol, and promptly informed the physician. Simultaneously, I delegated wound care and routine checks to the senior healthcare assistant and updated the team using our ward communication board to maintain clarity on task distribution. As a result, the DKA patient was stabilized within the first hour and transferred to a high-dependency unit without further complications. My ability to remain calm under pressure, prioritize critical care needs, and communicate effectively ensure that no patient's safety was compromised. Working in a medical surgical ward also strengthened my clinical documentation, multidisciplinary collaboration, and infection control practices. I learned the importance of continuous assessment and holistic care, addressing not only physical symptoms but also patient education and emotional reassurance. These experiences have built a strong foundation in acute care nursing, enabling me to adapt quickly, make evidence-based decisions, and deliver safe, compassionate care even in demanding environments.
Describe your proficiency with vital signs monitoring and interpretation. What would you do if a patient's oxygen saturation dropped to 88%?
Monitoring and interpreting vital signs is a fundamental part of my nursing practice. Over the years, I have become highly proficient in using both manual and automated monitoring systems, identifying early warning signs, and taking prompt, evidence-based actions. I routinely monitor parameters such as temperature, pulse, respiration, blood pressure, and oxygen saturation, while interpreting them in the context of each patient's baseline and clinical condition rather than in isolation. In one situation, I was caring for an elderly postoperative patient who had undergone abdominal surgery. During a routine observation, I noticed the patient's oxygen saturation had dropped to 88%. Recognizing this as a clinical red flag, my immediate task was to stabilize the patient and identify the underlying cause. I took rapid action by ensuring the patient's airway was clear and positioning them upright to aid breathing. I administered supplemental oxygen via nasal cannula as per protocol, while continuously monitoring saturation levels. I quickly assessed the patient's respiratory effort, lung sounds, and capillary refill, and verified there were no kinks or disconnections in the oxygen delivery tubing. I promptly informed the attending physician and documented all interventions and responses in the patient's chart. Meanwhile, I reassured the patient and maintained close observation, preparing for potential escalation if saturation did not improve. As a result, the patient's oxygen level improved to 95% within minutes, and the physician later identified mild atelectasis, which we managed with chest physiotherapy and incentive spirometry. This experience reinforced my ability to respond promptly to deteriorating patients, integrate assessment with clinical reasoning, and escalate care appropriately. I believe accurate vital sign interpretation is not merely about numbers. It's about recognizing subtle changes, acting early, and preventing further decline through timely, coordinated interventions.
Walk us through your process for administering medication safely. How do you prevent errors?
Safe medication administration is one of the most critical aspects of nursing practice, and I approach it with precision, vigilance, and accountability. My process strictly follows the 5 rights: the right patient, right medication, right dose, right route, and right time, along with 2 additional principles I personally emphasize: right documentation and right to patient education. In one situation, while working in a general medical ward with a high patient turnover, I was preparing to administer a dose of intravenous antibiotics. As I performed the task of cross-checking, I noticed a discrepancy between the prescription and the patient's electronic record, the prescribed drug concentration did not match the pharmacy's prepared label. Recognizing the potential for a medication error, I paused the administration process and took immediate action by verifying the order with the prescriber and confirming the correct dilution with the pharmacy. I also rechecked the patient's allergy history and ensured appropriate timing in relation to their other medications. As a result, the error was intercepted before administration, and the correct medication was delivered safely. The incident was reported through our hospital's incident reporting system, and later, I contributed to a brief war discussion on strengthening our double-checking procedures for 4 medications. Beyond this example, I consistently employ strategies such as scanning barcodes, using 2 patient identifiers, maintaining a distraction-free, no-interruption zone during medication rounds, and engaging patients by explaining their medications to promote shared responsibility. Preventing medication errors requires not only knowledge, but also a culture of safety and mindfulness. By combining adherence to protocols, effective communication, and self-discipline, I ensure every medication I administer supports the patient's recovery without compromising safety.
How do you manage a patient with a central venous access device, CVAD, or a PICC line?
Managing patients with central venous access devices, CVADs, or peripherally inserted central catheters, PICCs, requires a high level of aseptic technique, vigilance for infection, and consistent monitoring to maintain line integrity and patient safety. Throughout my nursing practice, I have managed numerous patients requiring long-term IV therapy, chemotherapy, parenteral nutrition, and hemodynamic monitoring through CVADs or PICC lines. In one situation, I was caring for a patient receiving total parenteral nutrition, TPN, through a PICC line in a medical ward. The task was to maintain sterility during administration, ensure correct infusion rates, and prevent catheter-related infections. During routine inspection, I noticed mild erythema around the insertion site, and the patient complained of tenderness. Recognizing this as a potential early sign of infection, I immediately took action by stopping the infusion, assessing the site for discharge, checking the patient's temperature, and informing the physician. I then collected a swab for culture as per protocol, changed the dressing using strict aseptic non-touch technique, ANTT, and ensured documentation of all findings and interventions. As a result, early detection prevented progression to a bloodstream infection, and the PICC line was preserved after antibiotic therapy. The patient's recovery was uneventful, and this reinforced the importance of meticulous line care and prompt intervention. My routine CVAD/PICC management involves daily site inspection for redness, swelling, or discharge, flushing the line with normal saline or heparinized solution to maintain patency, and ensuring secure, sterile dressing changes every 7 days or sooner if compromised. I also educate patients on avoiding excessive arm movements, recognizing signs of infection, and keeping the site dry. Ultimately, successful CVAD and PICC management relies on a blend of technical precision, infection prevention, and patient education, ensuring both safety and therapeutic effectiveness.
Describe your experience with wound care and dressing changes.
Wound care is an essential aspect of my nursing role, and I take pride in providing meticulous, evidence-based management to promote healing and prevent infection. My experience ranges from managing simple post-operative incisions to complex wounds such as pressure ulcers, diabetic foot ulcers, and surgical dehiscence. I have been trained in wound assessment using standardized tools such as the time framework, tissue infection/inflammation, moisture balance, edge of wound, and follow a septic non-touch technique, ANTT, during every dressing change. In one situation, I was caring for a post-abdominal surgery patient who developed a partial wound dehiscence with moderate serosanguinous discharge. The task was to prevent infection and promote healing while minimizing patient discomfort. I assessed the wound depth, size, and exudate, noting early signs of delayed healing due to diabetes. I then took action by cleaning the wound with normal saline, applying hydrofiber dressing for exudate control, and ensuring the wound edges remained moist but not macerated. I collaborated with a tissue viability nurse for further review and adjusted the dressing regimen according to the recommendation. As a result, the wound progressively improved over the following 2 weeks, with healthy granulation tissue forming and no evidence of infection. The patient expressed relief and satisfaction with the care received, and the case was later discussed during a multidisciplinary wound management meeting as an example of timely intervention and collaborative care. My approach to wound care combines technical skill with holistic assessment, addressing nutrition, glycemic control, mobility, and patient education. I believe wound healing is not just about dressing the wound, but about understanding the underlying causes and promoting overall recovery.
How would you explain a complex medical procedure like a colonoscopy to a patient who is anxious and does not speak English as their first language?
Communicating effectively with patients who have language barriers and anxiety requires empathy, cultural sensitivity, and the use of appropriate communication aids. In my nursing practice, I often encounter patients from diverse backgrounds, and I make it a priority to ensure they feel informed, respected, and supported throughout their care journey. In one situation, I was caring for a middle-aged patient scheduled for a colonoscopy who spoke limited English and appeared visibly anxious. The task was to ensure the patient understood the procedure, preparation steps, and aftercare instructions clearly, without causing additional distress. I first arranged for a professional medical interpreter to be present during the explanation, as I understand that relying on family members can lead to miscommunication or incomplete information. Using action steps, I spoke slowly, maintained eye contact, used simple, non-medical terms, and supplemented my explanation with visual aids showing the digestive tract and what colonoscopy involves. I explained that the procedure helps the doctor look inside the large intestine using a flexible camera to identify any issues like bleeding or growths, and that sedation would ensure comfort. I also reassured the patient that the team would monitor them closely throughout. I encouraged the patient to ask questions through the interpreter and verified understanding using the teach-back method, where the patient repeated key points in their own words. As a result, the patient appeared much calmer, successfully completed bowel preparation, and underwent the colonoscopy without complications. Afterward, he thanked the team for taking time to explain everything clearly, which reinforced for me how communication can reduce fear and build trust.
How do you ensure effective handover, shift report to the oncoming nurse, especially when you are busy?
Effective handover is essential to maintaining continuity of care and patient safety, and I treat it as a non-negotiable clinical responsibility, even during busy shifts. I follow the SBAR framework, situation, background, assessment, recommendation, which ensures my communication is structured, concise, and clinically relevant. In one situation, during a particularly demanding evening shift in a 32-bed medical unit, I had several unstable patients, including one awaiting transfer to a high-dependency unit. As the shift ended, I still needed to complete observations and documentation. The task was to provide a safe, thorough handover without delaying the incoming team or compromising ongoing care. To manage this, I took action by prioritizing the most critical patients first and updating their notes in real time throughout the shift. I summarized each patient's key details, diagnosis, current treatment, latest observations, pending investigations, and any risks using the electronic handover tool. For complex or deteriorating patients, I provided a brief verbal update at the bedside so the incoming nurse could visually assess the situation. I ensured clarity by highlighting any time-sensitive interventions, such as antibiotic administration or fluid balance monitoring. As a result, the transition between shifts was smooth, and no crucial information was missed. The oncoming nurse later thanked me for the clarity and structure of the report, which helped her plan her priorities effectively. In routine practice, I always check that the receiver has understood the information, encourage questions, and document all pending tasks clearly. Even when busy, I remind myself that a rushed or incomplete handover can lead to medication errors or missed observations, so I safeguard those few minutes as an investment in patient safety.
You notice a senior colleague has made a potential error. How do you handle this situation?
Addressing a potential error made by a senior colleague requires professionalism, respect, and an unwavering commitment to patient safety. I believe in maintaining a culture of openness and accountability where any concern, regardless of hierarchy, is handled promptly and respectfully. In one situation, while working on a medical ward, I noticed that a senior nurse had prepared an 4 antibiotic for a patient whose allergy status was marked as penicillin sensitive. The task was to prevent possible harm while maintaining professional integrity and team cohesion. I took immediate action by calmly approaching the nurse in a private and respectful manner, saying, "I just noticed this patient has a documented penicillin allergy. Could we double-check the medication order together before administration?" This non-confrontational approach allowed me to raise the concern without causing embarrassment or defensiveness. We reviewed the chart together and discovered that the antibiotic prescribed was indeed contraindicated. As a result, the medication was stopped before administration, the physician was informed, and a safer alternative was prescribed. The senior nurse later thanked me for speaking up, and the incident was used as a learning point in our team's safety huddle about the importance of allergy cross-checking before drug preparation. I learned that preventing harm must always take precedence over hierarchy. I handle such situations discreetly, focus on facts rather than blame, and document or escalate concerns through the appropriate channels if needed.
You have 5 patients. One is post-op and nauseated, one needs pain medication, one is demanding to be discharged, one's family is at the desk with questions, and one's 4 pump is beeping. How do you prioritize your care?
Prioritization in a busy ward setting requires a calm, systematic approach rooted in clinical judgment and patient safety. I rely on frameworks such as the ABC airway, breathing, circulation model, and Maslow's hierarchy of needs to guide decisions, always addressing urgent physiological needs before administrative or comfort-related issues. In one situation, during a hectic morning shift, I was caring for 5 patients with competing demands similar to this scenario. My task was to ensure safe, effective care delivery without overlooking anyone's needs. I took immediate action by quickly assessing the potential risks associated with each situation. First, I attended to the 4 pump because a beeping alarm could indicate an occlusion or completion of a critical infusion, potentially affecting fluid or medication delivery. Once resolved, I moved to the post-operative patient who was nauseated, as this could lead to vomiting and compromise airway safety. I administered the prescribed antiemetic after assessment and ensured side-lying positioning for comfort. Next, I prioritized the patient requiring pain medication because unmanaged pain can delay recovery and cause distress. I reassessed pain levels, checked the MER, medication administration record, and administered analgesia as prescribed. Once all urgent clinical needs were stabilized, I addressed the family's questions, providing reassurance and setting expectations for when I could return for a detailed discussion. Finally, I attended to the discharge request, reviewing orders and explaining that discharge processing would follow after safety checks were completed. As a result, all patients received timely, appropriate care and none experienced complications. This approach also minimized stress within the unit by maintaining communication and setting clear priorities.
A patient suddenly becomes short of breath and complains of chest pain. What is your immediate plan of action?
When a patient develops sudden shortness of breath and chest pain, my immediate priority is to recognize the situation as potentially life-threatening, such as a cardiac event, pulmonary embolism, or pneumothorax, and respond swiftly using the ABCD, airway, breathing, circulation, disability, exposure assessment framework. In one situation, while working in a medical ward, a middle-aged post-operative patient suddenly reported severe chest discomfort and breathlessness. My task was to assess, stabilize, and escalate care without delay. I took rapid action by first ensuring the patient's airway was clear and positioning them upright to aid breathing. I immediately attached oxygen via a non-rebreather mask and monitored saturation levels, heart rate, and blood pressure. At the same time, I called for urgent medical assistance using the hospital's emergency call system and requested the crash trolley. While waiting for the physician, I obtained a quick ECG as per standing protocol, maintained continuous oxygen monitoring, and reassured the patient to keep them calm. I also prepared to draw blood for cardiac enzymes once ordered, ensuring for access was patent. I delegated another nurse to inform the charge nurse and document vital signs at 1-minute intervals. As a result, the medical team arrived promptly, and the ECG revealed signs of myocardial ischemia. The patient was stabilized and transferred to the coronary care unit for further management. My immediate recognition and organized response helped prevent cardiac arrest and ensured seamless escalation of care. This experience reinforced the importance of remaining calm, following systematic emergency protocols, and communicating clearly with a multidisciplinary team during acute deterioration.
Describe a time you made a mistake in your nursing practice. What did you learn from it?
Reflecting on mistakes is a critical part of professional growth, and I strive to approach them with honesty and a commitment to learning. In one situation early in my nursing career, I administered medication slightly later than the scheduled time due to an unexpected urgent task with another patient. The task was to ensure timely medication administration while managing multiple competing priorities. I realized the delay immediately, assessed the patient for any adverse effects, and informed the charge nurse and prescribing physician. I then documented the incident accurately and completed a reflective analysis as required by our hospital's incident reporting protocol. Fortunately, no harm came to the patient, but I recognized that my time management and prioritization needed improvement. The action I took afterward was to revise my workflow, using medication rounds with reminders and incorporating short handover check-ins to flag time-sensitive drugs. I also started using a visual task board to track urgent versus routine interventions throughout the shift. As a result, I significantly reduced the risk of delayed medication administration in subsequent shifts, and my supervisor commended my proactive approach to preventing future errors. This experience reinforced the importance of vigilance, structured planning, and open communication. It taught me that mistakes are opportunities for improvement when handled responsibly, transparently, and with a focus on patient safety.
What does patient advocacy mean to you? Can you give an example?
To me, patient advocacy means acting as the patient's voice, ensuring their rights, preferences, and safety are upheld, especially when they are vulnerable or unable to speak for themselves. It involves recognizing patients as active participants in their care, supporting informed decision-making, and challenging systems or practices that may compromise their well-being. Effective advocacy requires empathy, clinical knowledge, and clear communication with both the patient and the healthcare team. In one situation, I cared for an elderly patient with dementia who was admitted for hip fracture repair. The patient was anxious and hesitant about surgery and unable to articulate their concerns clearly. The task was to ensure that their wishes were respected while still delivering timely, safe care. I took action by spending time with the patient, using simple language, and engaging their family to understand their preferences and anxieties. I communicated these concerns to the multidisciplinary team, emphasizing the patient's right to participate in decisions regarding anesthesia options and pain management strategies. I also advocated for non-pharmacological approaches to reduce anxiety, such as familiar music and gentle reassurance, alongside the clinical plan. As a result, the patient felt more involved and reassured, and the team adjusted the care plan to include their preferences. Postoperatively, the patient recovered without significant distress, and the family expressed appreciation for the way their loved one's concerns were addressed. This experience highlighted that patient advocacy is not only about intervening in clinical decisions, but also about creating an environment where patients feel heard, respected, and empowered, which ultimately improves outcomes and trust in care.
How do you ensure patient confidentiality is maintained?
Maintaining patient confidentiality is a cornerstone of ethical and professional nursing practice. To me, it means protecting all patient information, verbal, written, and electronic, from unauthorized access, ensuring that personal and medical details are only shared with those directly involved in the patient's care. It also involves creating an environment where patients feel safe to share sensitive information, knowing it will be respected and protected. In one situation, I was caring for a patient undergoing treatment for a sensitive condition in a busy ward where visitors and staff were constantly moving in and out. The task was to provide care while ensuring that the patient's personal health information was not inadvertently disclosed. I took action by discussing the patient's condition only in private areas, avoiding use of patient identifiers in shared spaces, and ensuring electronic records were accessed securely using individual login credentials. I also reminded students and support staff about confidentiality protocols before involving them in care tasks. As a result, the patient expressed trust and comfort, fully cooperating with care and openly sharing concerns that were crucial for treatment planning. My consistent adherence to confidentiality protocols also reinforced the team's awareness of safeguarding sensitive information, creating a culture of respect and accountability. I also follow hospital policies for secure documentation, ensure verbal handovers are private, and educate patients about who will have access to their records and why. Maintaining confidentiality is not just a legal requirement. It is central to building trust, promoting patient engagement, and delivering ethical, high-quality care.
Describe the process of obtaining informed consent. What do you do if a patient does not seem to understand?
Obtaining informed consent is a critical responsibility in nursing, as it ensures that patients are fully aware of the proposed procedures, their benefits, risks, and alternatives, and that they agree voluntarily. My approach involves providing clear, concise information, verifying understanding, and respecting the patient's autonomy throughout the process. In one situation, I was assisting with preoperative preparation for a patient scheduled for a laparoscopic cholecystectomy. The task was to ensure that the patient fully understood the procedure and was able to provide informed consent. I took action by explaining the surgery in plain, non-medical language, using diagrams to illustrate the gallbladder and incision sites. I outlined potential risks, post-operative expectations, and alternatives, and allowed time for the patient to ask questions. Recognizing that the patient seemed confused despite repeated explanations, I engaged a professional medical interpreter and encouraged the family to be present for support. I then used the teach-back method, asking the patient to describe the procedure and risks in their own words to confirm comprehension. As a result, the patient demonstrated a clear understanding, signed the consent form willingly, and expressed confidence in the care plan. The experience reinforced the importance of patience, tailored communication, and use of supportive tools to ensure that consent is genuinely informed. I also document all discussions carefully, noting any educational aids or interpreters used as part of professional and legal accountability. Obtaining informed consent is not just a formality. It is a patient-centered process that promotes trust, autonomy, and ethical care.